Good morning, everyone. This is the third lecture this semester. We are going to discuss the histology of dentine. I am Dr. Hibalzer. I'll be your host for this lecture. As usual, we will start with the outline of the lecture. We are going to discuss the building block of the dentine. Remember always to think about the building block of any tissue when you look at it under the microscope. This will make it really easier for you to recognize the kind of tissue you are looking at. So we are going to discuss the building block of the dentine, which is the dentinal tubules lying inside intertubular dentine. We are going to discuss everything related to the tubules, their curvature, content, and the intertubular dentine around it. Then we are going to discuss the regions of the dentine. When we take dentine and look at it under microscope, we are going to see different areas in dentine. We are going to discuss their shape, name, and characteristics. Then we are going to discuss the structural lines in dentine, like the ones we discussed in the enamel. Remember the enamel stria and the cross striations. We have something similar here, but some differences. At the end, we are going to discuss the age and post-eruptive changes in the dentine. To begin with, what is dentine? Dentine is the hard tissue that forms the bulk of the tooth and covered by enamel in the crown or cementum in the root. The composition is large numbers of parallel tubules in a mineralized collagen matrix. We'll see that in a minute. The tubules has a lot of contents. The dentine is a sensitive tissue. It has nerve supply. It has nerve terminals in the tubules, and it formed throughout life, which means it is regeneratable. It can be renewed, unlike the enamel. As you can see in this picture, there's a big difference between dentine and enamel. The enamel is whiter than dentine. The dentine is yellow and pale. It is harder than bone and cementum, but it's less hard, of course, than the enamel. It has tubular structure. There's tubules here. We'll see them in a minute, lying in a mineralized collagen matrix. It has higher compressive strength than enamel, a higher tensile and flexural strength. If you don't remember what these expressions means, please go back to the enamel lecture and see the video that explains all these physical terms to you. The dentine is permeable because it's composed of tubules, but this permeability decreases with age as the peritubular dentine closes the tubules. I think that you have seen the practical module by now, and I hope you have seen the introductory video talking about the dentine, which makes it easier for you to understand today's lecture and the practical module. If you hear any term that is not familiar to you by now, don't be afraid, don't panic. All these terms will be discussed thoroughly during the lecture. What is the chemical composition of dentine? So it's composed by 70% inorganic component, calcium hydroxyapatite as usual, 20% organic material, collagen matrix, and other organic materials we will discuss in a minute, and 10% of water. To start with, the inorganic material is the calcium hydroxyapatite crystal we saw in enamel. But here in dentine, look the difference between the crystals in dentine and in enamel. In dentine, it's really smaller. Why is that? Because if you remember in the enamel lecture, the calcium hydroxyapatite crystals stacks over each other to make what we call rod, which is the main building block of the enamel. In dentine, we don't have that anymore. So the crystals lie inside a collagen matrix, mineralized collagen matrix that has tubules between. So there is dentinal tubules here, and the mineralized matrix lies in between these tubules in a collagen matrix. That's why they are smaller. They don't stack, they don't form a mineralized structure like the rods in the enamel. The organic matrix, it's composed of a lot of structures, mainly collagen. 90% of it is collagen. Other components are non-collagenous proteins, protoglycans, GLA proteins, acidic proteins, growth factors, and lipids. All of these structures are more related to biochemistry and cytology, and that's why we are not going to discuss them here because they are a little bit far away from histology as a material. So you have to go back to the book and read. It's a homework for you. You have to read about the organic matrix, and of course, it is needed in the or asked about in the exam. Before we discuss the structure of dentine, the main structure of dentine, which is composed of tubules and intertubular dentine, I just want to remind you with this picture that is explained in the introductory video at the practical module. Remember throughout the lecture, the whole lecture, that dentine has many different regions inside that have different looking views or looking places under the microscope. So we have what we call the predentine, which is the first layer formed of dentine. There is primary dentine, the one that forms before birth and before occlusion. The secondary dentine that forms after the tooth erupts and it's in occlusion. And there is tertiary dentine that forms because of pathological problems. At the edge of the dentine, at the dentino-enamel junction, this is what's called mantle dentine. That's all what I want you to know before we start the talking about the building block of dentine, which is tubules and intertubular dentine. So if you hear any of these expressions during this section, you'll just have an idea what I am talking about. But all of this will be discussed thoroughly in a few minutes. So dentine, as I have said, is composed of large numbers of tubules sitting or lying in mineralized collagen matrix called intertubular dentine. Let's see that. So here is the pulp. We will discuss it next week. The odontoblasts, which are the cells that secrete dentine, and I have explained that thoroughly in the enamel lecture, how enamel odontoblast and ameloblast sits at a line here, and then the ameloblast start to go upwards on the surface, secreting enamel, and then the odontoblasts go inside, secreting dentine till the odontoblast sits in the pulp. The odontoblast is here, leaving their processes in the dentinal tubules they formed when they went back to the pulp. You will take that also thoroughly in the embryology lectures. So there is dentinal tubules going from the pulp to the dentino-enamel junction or to the dentino-cemental junction here and the root. And between the tubules, we have collagen matrix that is highly mineralized. If we take a longitudinal section of the tooth, we will see that in the crown, these tubules go in an S shape, as you can see here. But under the cusps or incisal edge, they are vertical, and in the root, they are horizontal. This is a longitudinal section of the dentine, showing this beautiful S shape of the tubules. So the tubules are not walking in a straight line, at least not in the crown. They take an S shape. It's called the primary curvature. The primary curvature of dentinal tubules. Remember this very well. While if we take a cross section of the tubules, if we take a cross section here near the pulp, as you can see, you will see it as round shaped then there is a lot of tubules. If we take a cross-section near the dentino-enamel junction, you will see it also as circles, but the size of the circles actually is really, really less, and we will see why in a minute. If we take a section here where the S goes up, the shape will be like slots, okay? If you remember this picture, the number of tubules near the pulp is much than near the surface, because the surface area becomes smaller near the pulp. That's why in a cross-section near the pulp, the number of tubules is much more than if we take it under the dentino-enamel junction. And why the tubules are larger near the dentino-enamel junction, near the pulp, sorry, that will be explained also in a minute. So this is how these tubules look in cross-section. They are circles. Inside of them, there is what we call odontoplastic process, and we will discuss that in a minute. And between them is the mineralized collagen matrix, the intertubular dentine. This is what we see if the section is partially mineralized. If we have a demineralized section, all the dentine inside the tubules is gone because it's highly mineralized, but the collagen matrix is still there. These dots are the odontoplastic process. We will come back to them in a minute. Don't be afraid. Remember the S shape we just talked about in the crown? The S shape that is called the primary curvature of the dentinal tubules. If we have a bigger magnification of this primary curvature, we will see that there is a little bit small curvatures inside of it. These are called secondary curvatures. Remember that very well. Secondary curvatures. If these secondary curvatures coincide with each other at some place, they make a line. I will show you in a minute. They make a line. This line is called contour line of Owen. This happens at many places, either inside the primary curvature, like we see here, or between what we call primary and secondary dentine, as you can see here. It's called contour line of Owen. So this is primary dentine and this is secondary dentine. And this line formed between them is called contour line of Owen. Also, these are the dentinal tubules with the small secondary curvatures inside. And when these secondary curvatures coincide with each other like this, see? They make what we call secondary line of Owen. I know these terms are a little bit complicated for you and hard a little bit, but when you listen to the lecture next time, I guarantee you everything will be really obvious and clear for you. So these are the contour line of Owens. Remember, there is this S shape, the primary curvature, S shape, and inside it, these small curvatures, when they coincide, they make contour line of Owen, or between the secondary and primary dentine. That's why I discussed what is primary and secondary dentine before I started. Again and again, I remind you, just take a look at the introductory video on the module I have downloaded last Friday. These tubules don't go just in a straight line inside the dentinal tubules and in the dentine. So they, as you can see here, they branch the whole way. They have lateral branches between tubules, and they have terminal branches. They branch at the end or the terminus of the dentine, whether it's near the enamel or near the cementum. So near the enamel, you can see at the dentino-enamel junction a lot of terminal branches like tree. In the cementum area, the branches make something called the granular layer of tomes, and we are going to discuss that thoroughly later on. So for now, you just have to know this, that the tubules branch during their path in the dentinal tubules, whether lateral branching or terminal branching. So if we look at these tubules, what do we actually see inside them? There is 5 components inside of dentinal tubules. First of all, of course, the odontoblastic processes, as you can see, coming out of odontoblast, going inside the tubules. We have the peritubular dentine that covers the tubule from inside. We have afferent nerve terminals and sensory terminals going inside the tubules. We have antigen-presenting cells, processes, and extradentinal fluid, or extracellular dentinal fluid. Let's take a look at each of these components. As you can see here, the odontoblast sends the process inside the tubules. They are responsible for forming the peritubular dentine, of course. Sometimes these processes go to the predentine area, and sometimes they go more in depth in the dentine. Sometimes they actually reach the dentino-enamel junction. If they don't, they leave a space like this, which is called periodontoblastic space, that we are going to see in cross sections in a minute. Why the length of the odontoblastic process varies? Sometimes it's only in the predentine, sometimes it goes a little bit deeper, sometimes it goes the whole way. This is something I leave to you to read. The hypothesis is in the book. Read it. I'm going to ask about it in the exam. If we take a cross section of the tubules, sometimes we see, like here, we see empty tubules because the processes didn't actually reach the this area. And sometimes we can see here the tubules, the odontoblastic processes inside the tubules. The second component is the afferent nerve terminals and the sensory terminals. As you can see here, the afferent nerve terminals go in a close relation with the odontoblast entering the dentine. If you take a cross section like here, you can see the odontoblastic process with the nerve terminals. That is going to be discussed again in the pulp lecture and practical module. The third component of the dentinal tubule is the antigen-presenting cell processes. As you can see, they are really in close relationship with odontoblasts, and they send their processes into the dentine. Most probably they stay in the predentine, but if there is a carious lesion, they can actually extend into the more deep part of the dentine called the circumpulpal dentine. The fourth component is the extracellular dentinal fluid. There is a fluid coming from the dentine pulp, from the dental pulp into the tubules. Of course, the odontoblasts are responsible for the composition of this fluid. It has higher potassium and lower sodium ions, which means it has higher osmolality that causes an outward pressure or positive pressure outside the dentinal tubules to help getting the toxins and pathogens outside the dentinal tubules if any carious lesion happens. The last and the most important component of the tubule is the peritubular or the intratubular dentine. As you can see in this picture, around the tubule or inside the tubule, there is this distinctive circle of dentine, which is different from the dentine between the tubules. That is called intratubular dentine, tubular dentine. So the peritubular dentine inside the tubules is very high mineralized type 1 of collagen. It's more mineralized than the intertubular dentine. And that's why when we have demineralized sections, it's all of it is gone away. All what we see is the odontoblastic processes inside and the collagen matrix of the intertubular dentine. In micrographs, microradiographs, or under electron microscope, you can see that the peritubular dentine looks like white circles that is different from the intertubular dentine. Here it has higher opacity in radiographs. The protein inside, the collagen protein inside the tubules is different than the collagen proteins in the intertubular dentine. In the intertubular dentine, it looks like fibers, but inside the tubules, it's amorphous, which makes it easier to mineralize it, makes it highly mineralized. Again and again, if we take a section at the pulpal end and a section at the dentino-enamel junction, the peritubular dentine occupies a lot of surface, more surface at the dentino-enamel junction because the odontoblastic process becomes smaller or actually sometimes not there. But at the pulpal floor, the odontoblastic process is bigger. You can see that here, if you can't imagine it. See here, the odontoblastic process is wider at the pulpal end and gets thinner and thinner as we go to the dentino-enamel junction. So at the pulpal floor, wider odontoblastic process, less peritubular dentine. At the dentino-enamel junction, smaller odontoblastic process, sometimes actually not there, and more peritubular dentine. With age, actually, the peritubular dentine starts to close these tubules. Sometimes that happens. All the tubule is closed with peritubular dentine, and most probably that's going to happen in the root, which makes the whole dentine composed of mineralized collagen matrix. There is no patent tubules anymore. If this happens and we take a ground section of the tooth, put it in water under light, what happens is all the places where the tubules are patent, which means open, will fill with water, while these areas that is closed by peritubular dentine will make the dentine having the same refractive index. The peritubular and the intertubular dentine will have the same refractive index that makes them translucent. So I can see the metal grid under them. They are translucent. And that is called translucent dentine, which is physiological, happens with age by peritubular dentine closing and occluding the tubules. In cross section, this translucent dentine looks like a butterfly because, as you know, the surface area is more toward the surface. So the tubule converge like this inside the, this is the butterfly shape of the translucent dentine. This is going to be discussed at the end of this lecture again, but I had to mention it here. Remember that translucent dentine is physiological. So we discussed the dentinal tubules with all of its contents. The other component of the dentine is the intertubular dentine, the one here between the tubules. It has a collagenous fibrous matrix, as you can see here. It's like woven wool, a lot of collagen fibers woven together. It has less density, less mineralization, and less density than the peritubular dentine, as I have mentioned earlier, and it's less mineralized. So is this section, as you can see, it's a demineralized section. I see amorphous collagen protein here, a little bit of it, while the intertubular dentine has a large matrix mesh of collagen fibers. This is, of course, odontoblastic processes. Next, we are going to discuss the different regions of the dentine. So the dentine composition vary from the pulp to the dentino-enamel junction. There is different regions. We will discuss their appearance and their names and why do they look the way they look. In the crown area, there is these 4 different regions. We will name them and then we will discuss them. The mantle dentine, the interglobular dentine, the circumpulpal dentine, and the predentine. In the root, we have the hyaline layer, the granular layer of tomes, then the interglobular dentine, circumpulpal dentine, and dentine, and predentine. Remember also that we can classify the regions of dentine in different way. I'm going to mention them now and we will discuss them later. The primary dentine, the secondary, the tertiary, the sclerotic, and the translucent. These are also regions of dentine, but we are going to discuss them as age and post-eruptive changes later on. So, first of all, we are going to discuss the crown. There is mantle dentine and interglobular dentine. What is mantle dentine? Mantle dentine is the most peripheral, here seen as a red line, first to be formed layer of dentine. It's different from the bulk of dentine beneath it, the one called circumpulpal dentine. It's 5% less mineralized. The collagen in it is perpendicular to the dentino-enamel junction. The branching of tubules happens in this area. As you can see here, this is the mantle dentine. It's different from the bulk of dentine underneath it. Another section showing the mantle dentine. Underneath the mantle dentine, there is a layer called interglobular dentine. It's not a mandate to see it. It happens because as dentine mineralizes, usually dentine start mineralization as globules, like this. Okay? If these globules fail to calcify, or these areas in between them don't calcify, okay, we see this area of interglobular dentine, which means the areas between the globules. They are hypocalcified areas found under the mantle dentine. And as you can see, the tubules goes through them really normally without any problems. We can see this area in the crown and in the root. Now going to the root, I will remind you with this slide. In the root, we have different layers. We have the hyaline layer and the granular layer of tone. What is the hyaline layer? It's a narrow, clear area between the cementum and the dentine. Here, the origin of it is not well known. Is it the cementum or the dentine? It's atubular and without structure. Add one's cementum to dentine. Underneath this layer, there is this area, this black area that looks like interglobular dentine, but it's not. It's called granular layer of tone. If you remember, we said that the branching of the tubules happens at the dentino-enamel junction and the cementum dentinal junction. In the root, this branching is really, really profuse, and the branches here actually loops. They loop like this. The dentinal tubule branching loops, and in ground sections, these loops are filled with air. That's why they look black like this. And because they are more profuse in the root area, they are seen in the root, but not in the crown. Of course, underneath it, we can see the interglobular dentine. We will see that later in some histological sections. The other 2 layers are found both in crown and in root. They are the circumpulpal dentine, which are the uniform dentine, making the bulk of dentine. There is no nothing special inside of it. Tubules in mineralized matrix. Near the pulp, above the odontoblast, there is this area of dentine that's called pre-dentine. That is the collagen matrix before it calcifies. And if you can see here, there's the start of globules, these calcipheres or globules start to calcify here. We call it the calcification front, the start of calcification. And then the calcipheres actually fuse together, making this uniform mineralized dentine. Just to summarize it again, so we have the mantle dentine, the interglobular dentine. In the root, it is different. It's the hyaline layer, granular layer of tome, and then the interglobular dentine, both in crown and root. The circumpulpal dentine, and near the pulp, there is predentine. We will see that at the end of the lecture in many histological slides. Right. Now we are going to discuss the structural lines in dentine. So we have three kinds of lines. The lines associated with the primary curvatures, the S-shaped curvature of tubules. The lines associated with the secondary curvatures of tubules, we call them Owen, contour line of Owen, and the incremental lines like the ones found in the enamel. Here they have different names. All of them are approximately perpendicular to the dentinal tubules. So let's discuss the first one. As you remember, we said that there is this S shape of the tubules from the pulp to the dentino-enamel junction. The line that shows us this convexity and concavity of the S shape, all the convexities come together to make a line, and all the concavities come together to make a line. These lines are called Schrager line. They are seen in longitudinal sections. They are very hard to see, and we are only going to see one, maximum two. One for the convexity, one for the concavity. And that's it. That is the only line that is associated with the primary curvature. The ones that's associated with the secondary curvatures are called contour line of Owen. They are caused by, as I have explained at the beginning of the lecture, with the small secondary curvatures inside the primary curvature, or by the neonatal line, because in dentine at birth, the neonatal line not only have a change in composition and mineralization, but also in the tube's direction, or as I have said, the line between the primary and secondary dentine. So as you can see here, remember, the primary is shape, the small secondary curvatures, when they come together, they have these lines. So as you can see, the secondary curvatures coincide like this and making these lines. In this case, the line is small. As you can see, it starts here and it ends here. Okay? They are interrupted. They are small lines, small contour lines of Owen. If it's a neonatal line, you will find it near the dentino-enamel junction, and also it is small. It doesn't go the whole thickness of the dentine, and most probably you will find one near to it in the enamel, or between the primary and secondary dentine. So these are the lines associated with the secondary curvatures of dentine, called contour line of Owen. The incremental lines, like the enamel, there is short-term striations called von Ebner lines, and long-term striations called Anderson lines. They are seen in grand sections. And as in enamel, they show the fluctuation in secretion of dentine, change in composition, mineralization, or collagen orientation. I think you remember something like that. We see something similar in the enamel. The von Ebner lines, which are the short-term, the almost daily deposition of dentine, is seen also only under high magnification, just like the crustaceans. Okay. As you can see here, they are really like 2 micrometers apart. really adjacent to each other. We really need high magnifications to see them. These are, of course, the dentinal tubules. The Anderson lines, or the long incremental lines, the long period incremental lines, they have 6 to 10 von Ebner lines in between, which means they, like the enamel stria, almost they are weekly intervals of dentine secretion. These are here, the white and the purple lines. Look here, they are. These pictures are took from the book. If you need to take a closer look at them, please go and take a closer look of them in the book. Okay. Also, in Anderson lines, sometimes we find exaggerated Anderson lines, hypocalcified ones, because of differences in mineralization. If this happens, we see these lines that walk the whole thickness of dentine. They are also contour lines of Owens, but they are caused by hypomineralization of Anderson lines. Okay? So, to summarize it up, it's very important to understand this slide because sometimes it's confusing. The contour line of Owens is caused by even hypomineralization of Anderson lines, as you can see here. If that happens, they are continuous, the whole thickness of enamel, okay? Or by secondary curvatures of dentinal tubules, as we see here. In this case, they are short and interrupted, or the neonatal line, or the between primary and secondary dentine. As we can see here, this is a contour line of Owen caused by hypomineralization of Anderson line, and this is a contour line of Owen between the primary and the secondary dentine. Remember, what is this? This is the mantle dentine. Yeah, and this is the circumpulpal dentine. Again and again, the neonatal line also could be considered one of the Anderson lines because there is a change in composition, mineralization, and the tubules direction. So the neonatal line could be considered an Anderson line or a contour line of Owen. The last section we are going to discuss is the post-eruptive and the age changes in dentine, which gives us different regions of dentine. In summary, they are called primary, secondary, tertiary, with the sclerotic and the translucent. The physiological happening ones happens with age are the secondary dentine and the translucent dentine, while the ones that are pathological are the tertiary, the sclerotic, and the dead tracts of fish. Now we are going to discuss them in details. So what is the secondary dentine? It's the dentine that forms once the root is completed and the root comes to occlusion. So it forms slowly. It's very similar to primary. The only thing that happens that there is a change in the tubules direction, making or having a line or contour line of Owen between the primary and the secondary. This is the third time we mentioned this in this lecture, so I think now it's very obvious and clear to you. It has a slower deposition. The incremental lines are closer, of course, and the secretion of it is faster on the pulpal floor. With age, the more secondary dentine deposited, the smaller the pulp chamber and the roots become. As I have said, if the secondary dentine or the peritubular dentine occludes the dentinal tubules completely, that will make what we call the translucent dentine. So this is secondary and primary C, the contour line of Owen. Secondary and primary contour line of Owen. And this is again when the dentine occludes all the tubules. So the peritubular and the intertubular dentine have the same refractive index, and they refract light the same way, makes them translucent. In cross section, they look in a butterfly shape. Remember, again, translucent dentine is physiological. In a minute, we will talk about something called sclerotical dentine, which has the same shape and the same feature appearance, but it happens because of a pathology, a stimulus, a pathological stimulus. We'll come back to it. Tertiary dentine is the dentine that is secreted because of a pathological stimulus, of course, like trauma or carious lesion or cavity preparation. It has many names: irregular secondary dentine, reparative dentine, reactionary dentine, response dentine, and osteodentine. Why is that? Because each stimulus make the odontoblast react in different way. And that's why the tertiary dentine may have many different appearances under microscope, many and different composition. It could be tubular, atubular, structureless, with structures, with cells, without cells, as we going to discuss here. See? So this is the normal tubular, beautiful looking dentine. When stimulus happens, sometimes some odontoblasts die, so the tertiary dentine has a little number of tubules. Sometimes the odontoblast gets inside the dentine, so we can see cells inside the dentine. Sometimes we'll have weird-looking tubules in different directions with cells inside, and sometimes the odontoblasts die actually, and what happens is some kind of sclerotic dentine inside without tubules. There is no tubules at all. It's structureless with cells, dead cells inside, and some mineralized tissue. As we can see here in this slide, there is tertiary dentine. It is not uniform. We can't see a tubular structure inside of it. This is another section of with high magnification. As you can see, it's just haphazard collagen and mineralized matrix. Sometimes, if the carious lesion is slow going, that gives some chance for the odontoblast to occlude all the tubules under the carious lesion, to prevent the carious lesion from getting inside the patent tubules. If that happens, remember what happens if we occlude the dentinal tubules, the peritubular and the intertubular dentine have the same refractive index and they become translucent. But in this case, it is not physiological. The dentine becomes translucent, but because of this slow-growing carious lesion inside the pit. So this dentine is occluded, all of the tubules is occluded, but now we call it sclerotic dentine, despite it's translucent. But because it's pathological, we call it sclerotic dentine. If the stimulus or the carious lesion or the harmful stimulus is very, very strong, what happens is the odontoblast die. If they die, the tracts or the dentinal tubules above them become empty. And what happens when we make a ground section of this empty tubules, they are filled with air and they look under light like black lines. These are called dead tracts of fish. The odontoblasts here are dead, and the tubules here are empty and filled with air. Look at the big carious lesion here. Another slide showing sclerotic dentine happened above the odontoblast, trying to occlude the tubules, and above it there is the dead tract of fish. This is all what are we going to discuss today. I'm going to take your questions in a minute.